All right, welcome everybody to a joint Eureka Springs Hospital Commission and City Council workshop, June 4th. So I think right off the top, what we have is an introduction and presentation by Bo Ryle, President and CEO of Arkansas Hospitality Association. And I think you're on Zoom. Can you hear us, Bo?
No.
No.
What's he with? The hospital?
Arkansas Hospital Association.
Oh, okay.
Right.
Hospital. Hospitality.
It makes more sense.
He said the former a lot of times in the past.
While they're waiting for that, for Bo, maybe we can introduce ourselves.
Oh, I'm Steve Holofield, City Council.
Harry Meyer, City Council.
You, Dave.
David Carlisle, Commissioner.
Kate Dreyer, Secretary.
Brian Byler, Vice Chair.
Sandy Martin, Chair.
Jody Edmondson, Interim CEO.
Cynthia Asbury, CFO.
And Butch Berry, Mayor. So, all right, Bo, can you hear us?
I'm sorry, Butch, what's his name?
I was asking Bo if he could hear us.
What is his name? Please.
I think Bo can hear us, but we can't
Bo.
hear Bo.
Ryle.
Ryle.
Lyle?
Ryle.
R-Y-A-L-L. Still have a hard time hearing you, Bo.
Testing, 1, 2, 3.
Testing.
Try again, Bo.
Testing.
Perfect.
Yeah, we got it.
Oh, got it. Good. All right. Are we ready to begin?
Yes, sir.
Okay. Thank you so much. And thank you for having me here today. I appreciate the opportunity to make a few remarks at your meeting and just tell you a little bit about the Arkansas Hospital Association. And I'm Bo Ryle. I'm the President and CEO. Arkansas Hospital Association has been around a long time. We've got 105 hospitals that are members of our association. We really focus on advocacy in the state and federal level. We have a good government relations team that works the state legislature and members of Congress. We also have a great communications team. You may have seen our magazine in the hospital, weekly newsletters, internal and external communications. We also have an education division that not only provides an annual meeting to our members and the summer meeting, but also great educational opportunities for individuals that work in hospitals. We also have a data division that provides a lot of data back to hospitals. We take a hospital discharge database and return that back to hospitals so they can look at services, market share, quality, those type of things. And then we also have a quality division that has a couple of nurses that will help hospitals improve their quality within their hospital system. So on the federal level, we partner with the American Hospital Association to make sure that we're always in stride with them. So I've sent a PowerPoint. Do y'all have that in front of you, pages? So I'll just call off what pages I'm on, if that's all right.
You want to bring yours up? We've got it loaded too, Bo.
Okay, so you're going to bring it up?
Yeah.
Okay, thank you, Sandy.
And we also have copies we'll distribute to everybody after Bo's presentation. There you go.
Okay, how about the second slide? Okay, I just wanted to show this map. This is a map of hospital closures since 2005. You'll see in Arkansas there's only been 2 closures. That was West Memphis and DeQueen. And those hospitals the good news is those hospitals have since reopened under different owners. So since 2005, we have not had a hospital close that did not reopen. That's good news. We think that's because Medicaid expansion. So in 2013, the state of Arkansas, the state legislature passed Medicaid expansion, which increased insured levels and beneficiaries of 220,000 Arkansans were able to be on Medicaid. So that helps hospitals by having insured patients. You can look at some of the other southern states across there. They did not provide Medicaid expansion to their citizens, and so they had hospitals that closed at a higher rate than we saw here. That's not to say that there's not still challenges for hospitals across our state. Arkansas Business, a magazine here in Little Rock, looked at the finances for hospitals across the state and found that 40% were operating in the red, and 70% of those operating in the red were rural hospitals. So still challenges ahead for Arkansas hospitals. Next slide. I know y'all been through this transition recently from a critical access hospital to a rural emergency hospital. You can see here the key differences between those two. Critical access hospital has inpatient services, whereas a rural emergency hospital does not have inpatient services. There are exceptions for observations and such, but no inpatient beds. The length of stay for a critical access hospital is 4 days, whereas in a rural emergency hospital it's 24 hours. They both have emergency departments, but the pay is different. If you see there, Medicare pays critical access hospitals 101% of their cost, but with sequestration, it's about 98%. And then Medicare pays rural emergency hospitals 105% of their standard outpatient rates, and they receive a monthly facility fee. So this transition, as you've done, has been attractive to small rural hospitals that are struggling, critical access hospitals. So as you'll see on the next slide, that's how many rural emergency hospitals there are across the nation. There are 40. In Arkansas, we've got 5, Eureka Springs, Pocahontas, Osceola, Helena, and DeWitt. So it's still early as far as these transitions for us to have financial data here at the Hospital Association. But next slide, please. I wanted to show that if you look on the top bar there, that's the emergency department, and this is the payer mix for hospitals across the state. So payers affect the viability of hospitals. So looking across that, it's commercial insurance, Medicaid, Medicare, and self-pay. So let's start on the right side of the emergency department. Statewide, 12% are self-pay or no charge. Really, that's people who come in who have no insurance, no real payer source, and then the hospital is expected to absorb the cost of that patient. Not a great business model, but the one we have for hospitals. Medicare is 20% of those in Arkansas. There are 430,000 people on Medicare in Arkansas, and as you know, that's for people 65 and over. Medicaid, that's 28% of the payer source in Arkansas. You may think that you don't know anybody on Medicaid, but Medicaid is 880,000 people in Arkansas. And Medicaid covers 60% of the births in our state. It covers disabled kids, it covers behavioral health, and it covers the the elderly in nursing homes. So it covers a lot of our Kansans, a lot of our friends and neighbors. The last category there I'll mention is the commercial insurance category. Those are negotiated rates with companies like Blue Cross Blue Shield and United. And I say negotiated loosely because the hospital the size of Eureka Springs does not have the leverage to negotiate, so those payment rates are given to them. There is a large growing segment of this commercial insurance population called Medicare Advantage. You've seen the advertisements on TV, you've seen the desks set up outside of Walmart trying to encourage people to change from traditional Medicare to Medicare Advantage. We have about 220,000 people on Medicare Advantage, and it's growing every day. Next slide, please. Medicare Advantage is, we would call it a disadvantage. People who move to Medicare Advantage are not on Medicare anymore. They're on a private company's insurance. And what we found is that they put up all kinds of obstacles to paying hospitals and delivering care to patients. So you can see on that right-hand side, 98% of those companies require prior authorization for any procedure. So the doctor and the hospital are jumping through all kinds of hoops to try to get something approved, and ultimately it still may not be paid for. So Medicare Advantage plans, they delay payments, they have restricted coverage, and they have lower payment rates. So if you'll think about traditional Medicare and a patient that's in our area, if the hospital would get 100% of that rate, but because of all the hoops that we have to jump through as hospitals and doctors for a Medicare Advantage plan, we usually get about 92% of that 100% of Medicare. So this program is really hurting hospitals, and particularly rural hospitals where Medicare Advantage programs are growing at a high rate. Next slide. Hospital expenses, we all know about inflation. Hospital expenses are rising as well, even higher than inflation. Hospital, three major categories of expenses: drugs, labor, supplies, have gone up 17.5% over the last 3 years. So that is a huge concern for hospitals. And so we all know that labor, the doctors, the people who, physicians, nurses who work in hospitals, that's 56% of expenses there. Supplies are 13% of expenses, and drugs are 9% of expenses. So all those categories have gone up, which has made it really difficult on hospitals to survive. So hospitals differ from other companies in that we cannot just raise prices to offset expense increases. So unlike a restaurant with the price of eggs going up, the price of omelets would go up as well. For a hospital, it does no good to raise the prices. Prices don't impact those commercial insurance prices, and they don't impact government agencies who are reimbursing hospitals like Medicare and Medicaid. So in summary of the financial portion of this program, revenues are flat for hospitals. Expenses have increased a lot over the last 3 years, which has really made it a challenge to have a positive line for hospitals. And it's not just small hospitals, it's big and small. They're struggling right now. Next slide. So I'm going to switch now to a congressional update, what's going on in Congress. So next slide. You all have heard about the one big beautiful bill that's being considered by Congress right now. You probably read what's in it, tax cuts. They're going to make the tax cuts permanent from the first Trump administration. They're proposing to raise the debt ceiling, which they need to do by mid-July, and they're also proposing $2 trillion in spending cuts. So we're concerned because a lot of those spending cuts are Medicaid, and Medicaid is very important to having people insured in Arkansas and having a payer source for hospitals. Next slide. Thank you. So where it is in the process, the budget reconciliation bill, the one big beautiful bill, has passed the House on May 22nd. It's now being considered by the Senate. It takes 51 votes for passage. And right now they've started Senate committee hearings to talk about what is going to be included in this piece of legislation. So it could be changes, it could be approved in the same way. Next slide. So we're concerned about potential Medicaid policy changes that would ensure that people lose coverage. So one of those is work requirements. It might sound like a good idea for Medicaid recipients to have a work requirement, but we went through this 5 years ago in Arkansas. If you will remember, we were the only state to implement work requirements for Medicaid recipients. We lost about 2,000 to 4,000 people a month lost coverage. What we found on this process that it's complicated. It's hard to report. They utilized a portal for Medicaid recipients to enter if they were working, the amount of hours. That was difficult to do. And then there was also a lockout period. So if you didn't report that you were working for 3 months, then you were locked out of the program for the rest of the year. So those people who are locked out of the program and lose their Medicaid coverage, they still need health care coverage. They are still going to go to the hospital emergency department. They're still going to be served, and it's going to be expected that the hospital absorb those costs. So we do not want to see work requirements passed through in this legislation, mainly because it's going to impact hospital finances and people will lose their coverage. There's also going to be eligibility and enrollment rules, going to make those more difficult for people to stay in the program. And then also it's going to limit the use of provider taxes. So in Arkansas, hospitals, nursing homes, ambulance providers all utilize provider taxes to supplement payments because Medicaid payments are so low from the state. So we tax ourselves, we send it to the state uses it to draw down federal dollars and return to hospital, nursing homes, and ambulance providers as supplemental payments based upon Medicaid patients. This really helps the payment scheme for Arkansas. It really allows us to serve Medicaid patients better and more. Legislation proposes a freeze of that, so from our standpoint, we're a low-cost state. Our provider assessment is 2%, where other states have 6%, so we feel like it's unfair to freeze it at this level, so big states like New York and California will have a better percentage than Arkansas. So we oppose that section of the bill. So in total, the Medicaid policy changes are estimated that 8.6 million will lose Medicaid coverage across the nation. We've seen estimates that Arkansas could lose 87,000 people to Medicaid coverage. So we're very concerned about how that, if that gets passed as is, those people lose coverage, they're going to show up in the emergency department without insurance. So it's going to affect hospitals, it's going to affect healthcare in Arkansas. So an action item I would say is I hope that to help our hospitals, to help our citizens, you would contact Senator Cotton and Senator Bozeman's office and say your objections to the Medicaid policy changes in this bill. They cut too far. They're hurting hospitals, they're hurting beneficiaries. Next slide. So a little more positive note, the state legislative session ended in April. Next slide. Our number one priority, as it has been since 2013, is Medicaid expansion. So that passed during this legislative session. If you remember, that covers 220,000 Arkansans. We hope it still is intact after the federal legislation is passed, but it's been great for hospitals, great for coverage of people. So that passed this legislative session, and we're appreciative of that. Next slide. Maternal health, we are ranked last in the nation in maternal health. We have 33 hospitals that deliver babies in Arkansas. That's down from about 45 a couple of years ago. So we were very pleased that the governor and the legislature passed the Healthy Moms, Healthy Baby legislation. It increases reimbursement to hospitals that deliver babies, and it unbundles a lot of services so that individual providers can be reimbursed for serving pregnant women during their time of pregnancy. Next slide. Health insurance. So the first act there I'll talk about, so when a doctor or physician moves to town, they have to have their credentials approved by the state medical board. So they submit a packet, it gets approved, and the next step is it has to go to an insurance company for them to approve the same credentials. This can take 9 months to a year. In that 9 months to the year, their insurance company is not paying the physician. So we work to pass a law that says that once it's approved at the state medical board level, then the insurance company has to pay retroactive back to that date. So we think this is going to speed up that process of getting physicians approved credential-wise to serve in communities. Second piece of legislation I'll mention there is the Gold Card legislation. We mentioned prior authorization difficulties for Medicare Advantage plans. This piece of legislation allows, if a doctor files for prior authorizations and gets approved at a 90% rate, then that doctor is approved for the next year for any prior authorizations that they submit. There will be no long process, an approval process. So if the doctor deems a procedure or treatment necessary, then it is approved. Next slide. So in the pharmacy space, legislation passed in the 1970s which prohibited nonprofit or state government-owned hospitals from holding a retail pharmacy license. So we have been trying to change this legislation for now 50 years, and it was changed this legislative session so that nonprofit and government-owned hospitals can have a retail pharmacy permit on their campus. Good piece of news there for hospitals. Next slide. And finally, workforce, we saw some improvements there. It's always been difficult for insurers to make network determinations for physicians and non-physicians. They take a long time. We've reduced that time that they must do it from 180 days to 90 days. So a good piece of legislation there. And then also the second piece I'll mention, a licensure pathway for certain medical students serving in medical underserved areas. We think that's going to help small communities get medical students and physicians there. So I'll be happy to answer any questions, but I would say just in summary that hospitals are struggling financially across the state. It's not just the small ones, it's the big ones as well. The second part of the presentation, Congress is considering Medicaid reductions that would ultimately reduce the number of Arkansans on Medicaid. That's going to hurt hospitals, those people who will not be penalized for not having Medicaid, but they'll show up at the emergency department and inspect that the hospital will absorb those costs. And then finally, the governor and the state legislature passed some very good pieces of legislation that help hospitals and access healthcare services, so we're very pleased with that. So with that, appreciate you allowing me to speak to you today.
Thank you both. That was great. Lots of good information on the front. Does anybody have any questions for Bo?
I guess, Bo, my question would be to you. You've seen Eureka Springs as far as overall the new REH. What do you feel from your perspective how we look as a hospital going forward? Did you hear me? Bo, can you hear me?
No, he can't. He's not receiving.
Sorry, I'm not hearing anything if you are speaking.
Bo, can you hear me now? 1, 2, 3. Well, I'm losing. Can he see us?
Yeah.
Sorry, I can't hear.
Bo, give me a second.
Yeah, he can't hear us though.
Bo, can you hear me?
I can hear you now, yes.
All right. So, Bo, my question to you was, us being a REH hospital, moving forward, how do you see, Eureka Springs as a hospital with the new program? What you feel? I know you've shared about the cuts and stuff, but what do you see overall where we're heading, or what possibilities we may face?
Well, certainly, as I mentioned, the expenses in running a hospital these days, operating a hospital with inflation, those have gone up quite a bit, and having a stagnant or flat revenue stream as far as, I'm sure your CFO and CEO can talk more about your payer mix there. You're probably heavy Medicare and Medicaid, so those payers are not increasing at a fast enough rate to keep up with inflation. So it makes it a struggle for hospitals. I guess I would defer for any specifics from your team there from Eureka Springs. I'm sure they have all of that information.
Okay, thank you.
And is there a separate push to get an increase in Medicaid and Medicare for REH hospitals to make up the difference?
There is a push for those and push for all hospitals, but right now the focus is trying to stave off the cuts that are focused on Medicaid and focused on hospitals at this time. There's no Medicare reductions that are on the table, but those Medicaid reductions would be very extreme as far as people not having coverage and then, as I said, showing up at the hospital and then being absorbed into the expenses of a hospital. And as we know, we don't have enough room to absorb patients who have no ability to pay.
Right.
So, Bo, kind of tying into what Sandy was asking, since the rural emergency hospital concept is something that originated in the federal government, in D.C., as I understand it,
Right.
since this is their baby and we chose to adopt a program that they were really excited about, I'm wondering, not hospitals overall, not acute care, but is there talk about there being a special dispensation for just the rural emergency hospital when it comes to some of these cuts?
I would say no. No, that's not a consideration going down to, I think there's 40 hospitals, so they're really focused on a larger picture in DC. So I don't see a specific carve out for rural emergency hospital.
Okay, thank you.
Question. From the information that I've received, the Medicaid expansion with the Affordable Care Act just
Right.
it may die in Arkansas because of the cuts at Medicaid. If they go through the Senate the way they've gone through the House, we can sort of kiss that part of the Medicaid expansion goodbye.
That's definitely a possibility, yeah. It's definitely a possibility, and we have voiced our opinion to our congressional delegation about that. We have to see Medicaid expansion continue for Arkansas. That's just, there's too big of an impact as far as people losing insurance and its impact on physicians and hospitals.
Well, the state adopted Medicaid expansion because it helped the state out a lot. You know, I think there were 10 states that decided, no, we're not going to mess with that Medicaid expansion, but at least, of course, Arkansas has to have a balanced budget, so that's what they use to help balance their budget. And but I don't think that the people in Washington care much about Arkansas maintaining anything at all.
I think you're right on. We're working our side of the congressional delegation and our senators, but yeah, there's 48 other senators or 98 other senators who not concerned about Arkansas.
Bo, other than contacting at the federal level and certainly the state level, our representatives, what can we do to help you help us?
That is it. That is it. I think this Medicaid policy decisions that the Senate is considering right now are so important. So anything you can do to contact Bozeman and Cotton's office and talk to them about the potential for these impacts on your small hospital, I think would be helpful.
I call them daily.
Thank you.
I do.
And are there talking points up on your website?
Sure. We'll make sure, and I'll send some to you just in case.
Okay. Appreciate it. Thank you.
Yeah.
Do you think that outreach to HHS would be helpful at all, or just the Senate?
I think just the Senate right now. I don't think reaching out to HHS would have much impact at this
Okay.
point. We'd have to go through our senators to have an impact.
Okay, thank you.
Bo, is there anything that you think of that our hospital can do to help its financial footing?
Well, I would say I don't really have the insight into your finances to know that, but I see where your team there at Eureka Springs is about to make a presentation, so I'm sure they'll have better insight than I.
Okay.
The only other question I have, it might not necessarily be for you, Bo, maybe just for Cynthia, or both of you. The slide that you put up there about the changes in Medicare Advantage and how more people, retired people are the numbers are increasing in the Medicare Advantage pool and less in the regular original Medicare. And did I see the slide correctly that our reimbursement is not as great with a Medicare Advantage patient as it is with an original Medicare patient?
Correct.
That is exactly right. Yes. So traditional Medicare patient gets let's say 100% of the rate that's prescribed, but a Medicare Advantage plan pays much less when you take into account that it takes time and money to get the prior authorization approved. They're going to deny the claim, first of all. They're going to slow pay us, maybe sometimes even not even pay us for the service that we provided. So then when you factor all those things together, it could be 92% of that 100% of a traditional Medicare payment.
Is it because more money is going to the provider, to the carrier, let's say Humana?
Well,
And it's,
I think their ultimate goal is to squeeze the payments so they can make a higher profit.
okay.
So yes, they're keeping the difference.
Okay, and well, I can talk to Cynthia about prior auths and turnaround times and things like that offline. We don't have to take up that time today. Thank you.
Sure, thank you.
Yeah, so as far as a question of thought of what we do here in Eureka, it's looking at how many clients do we have coming in the door that are Medicare Advantage, and just overall knowing that those are our challenges to deal with when we're getting into the billing side of that. And especially that pre-authorization business hits home hard.
Yeah, well, and Cynthia she updated it at our workshop, updated us on the conference that you went to.
Yep.
That lots more Medicaid and Medicare questions and challenges. Coding.
Yeah, the reimbursement reductions within coming down the pipe for Medicare and Medicare Advantage is Medicaid, so.
Bo, what's your feeling about telehealth and mobile clinics within the environment? Because, I mean, things are changing and we're being forced to change, yet we have no idea where we need to go exactly. Where do you all see that going? How should a rural hospital prepare for the future?
Well, I think as far as telemedicine, telehealth, it certainly needs to be utilized. Now, trying to determine whether an insurance company or Medicare or Medicaid is going to reimburse for those services is very difficult. So I think certainly a lot of research has to go into what services you want to provide at that level and get to be able to get reimbursement for that level of telehealth. And then the mobile units, there was legislation passed during the session that made it easier for the mobile units to move around and use services and go to smaller communities. So I think we'll see an expansion in that area as well.
Bo, you said you had 100, am I right? You have 100 hospitals basically a part of the association?
That's right.
So my question to you, the one thing we're looking at now is looking for those services that we can offer that will help the bottom line. So in your hospitals that you deal with in that 100, are there certain services you guys have really helped go after, or are there ones you can enlighten us with that we might want to look at in order to better our situation in Eureka Springs?
In our data program, we have some of that information, and if you will, let me get with our data person, Donald McCormick, and find out what those services and share that with you guys. I think that would be better than me trying to talk off the top of my head here.
Thank you very much. Sure, we appreciate that.
Yeah.
Sure.
Anybody else? Bo, we sure appreciate you spending the time with us, answering the questions in your presentation. It's very informative and very valuable to us. And we're proud members of the AHA, and we'll help you lobby as much as we possibly can. And we appreciate your efforts on our behalf as well.
Thank you so much,
Thank you so
Bo.
much. I appreciate the opportunity, and we're certainly here as the Hospital Association for any services, any contact that you need, and I'll follow up with those 2 items.
Thank you very much.
Thank you.
Bye-bye.
Thank you.
That was great.
Okay.
That's good.
It was very informative. I think it was great. Okay, next we want to kind of do a financial overview of the hospital, and Cynthia is here, so I'll turn it over to you so that we can share a better understanding of our finances.
Where would you like me to start? Specifically, anything you want me to start with, or just kind of?
Just kind of start with going through the buckets, I guess, our line items, so there's an understanding of what goes in there and why we have these line items as well.
Are you looking at this?
Yeah, just go over that. Yeah.
So within the document, I mean, we have, and this is referencing back to our income statements and within our budget, our outpatient revenue, which mostly is from our ER services. We do have radiology and then lab as well, and speech therapy, looking to increase. And we've worked with Rural Health redesign team at some areas to expand revenue within that. The only other revenue would be we'd have our clinic leases for therapy spaces in the clinic across, and then we have our monthly stipend from CMS for our REH conversion, which would be in our other revenue. Other than that, we have our deductions from our revenue, which is our contractual adjustments. And kind of like what Bo was saying there, I mean, our reimbursement rates are not, Medicare is our best payer. Our mix is probably about 30 to 40% Medicare. Medicare Advantage plans are kind of taking that over, unfortunately. And we do have a large population of Medicaid or Medicaid payer types. So our reimbursement on those is pennies on the dollar. So our contractuals monthly is going to vary depending, again, on our payer mix. So, I mean, there's no, I say, control within that. Excuse me. And then, I mean, the only other really deductions we have from that will be just our other contractuals, our charity care or courtesy discounts. And I know we talked about that, our budget workshop, our charity application and stuff like that online that's available for patients that need that. And then, I mean, our bad debt expense, again, that is from any of our accounts that have returned from collections. And then below that will be all of our various expenses, which is going to be from our salary, benefits, supplies, contract labor. I mean, just like he was saying, with inflation, I mean, our prices are going up. We're doing what we can to control those, to watch those numbers and maintain it within a balance. I think we've determined, we said about $550,000 a month is our kind of average expenses, kind of what we anticipate. Continuing to look at contracts, continuing to look at any way we can to reduce costs and expenses in that area. So, anything else?
And we're, again, a reminder that we have gone from MedHost, medical records provider, to Cerner/Oracle. So a lot of the crossover, a lot of the data is different, and Cynthia's been working on that too, and I think you're going to revise some of the line items in the way the financials are reported out. Is that right?
Correct. Because some of them were line items from MedHost that they had, transactions hit at some point in time from 2020 to 2024. So those line items had to be kept open as we done the conversion. So as we work through with the Forbes and everything, we're seeing what line items we can consolidate to make it more fluid and having less buckets to put transactions into. So,
Do you have a breakdown on salaries versus contract labor?
Yeah, we do that in the budget.
Yeah.
It's not here in this, that's all.
No, this is just a blank thing in our budget that you've been provided. We have that in the financials that you receive. You have that itemized.
Is it normally presented over here? Sorry. Is it normally presented without amounts in the line items?
No, this was just today for point of discussion.
Okay.
No, you get, we've sent out the copies of the financials that have the line item detail on it every month.
Can you explain what you feel the difference is between contract labor and salary and how that works out?
correct. I mean, back in 23, we done a cost benefit analysis within our contract labor versus our current staff, PRN, on-call pays, callbacks, call-ins, things like that, overtime that was paid to staff. And within that cost benefit analysis, we had pretty equivocal between the benefits we were paying employees and overtime to what our contract labor currently runs. The benefit to our contract labor is as well, we do not have as many call-ins. We don't have as much issues of, say, our director of nursing or CNO or somebody having to cover a shift after working, the 12-hour day shift. So
did it feel like to you, Cynthia, that it was kind of pretty even?
the numbers were pretty even, but then we had the positives of that, like I was saying, was with the more consistent schedule coverage. They work their 3 12-hour shifts. That's typically what their contract requires at minimum. And most of them are even willing sometimes to pick up other shifts because they're here out of the area.
Because it's that non-cash expense of insurance and holiday
Benefits, tax,
and
matching,
the Social Security tax and all of that, the
But-
benefit package that
Yes.
comes with a regular employee as
Full-time
opposed to, so all of that, along with the non-monetary of where you're saying our call-ins aren't as great and things like that, that it's over a 12 or 24-month period, your numbers are kind of coming out to where it's kind of 50/50?
They're equivocal, correct, yes.
So our contract labor program basically is we contract with a company, as you guys probably understand. So if we have somebody that's just an hourly employee working in the area, lives in the area and calls in sick, we have to scramble to cover that situation. Where with the contract labor program, they cover that situation. So it's a great little incentive-wise because they're responsible to make sure all the shifts are covered. And they've done a great job with us on that, if I'm understanding correctly.
Correct, our overtime has significantly went down. I mean,
I know y'all mentioned that in the workshop a couple days ago. I thought that was interesting. So you're saying a full-time employee is equivalent to contract workers coming in and working 30 hours or 30 days a month or whatever their 40 hours a week would be.
typically it's 36 hours a week between their hourly pay and their benefit package, correct, and then counting in the overtime we were paying because of the called-in and missed shifts that we were having to cover, or...
So it's including the overtime,
Correct.
but not just regular, if it's person per person
We
per shift.
looked at the average of what we were paying in overtime to cover our nursing department and ER, and that is what we averaged that out with, correct.
So is the goal of the
That said-
hospital to just use contract workers from now on, or are you going to try to hire full-time staff?
No.
We have full-time employees, and we are actively and continue to, I mean,
It doesn't replace that. We would prefer to have local employees on it, particularly because it's a wash.
I'm glad to
However,
hear
the
that.
contract labor has saved our bacon, and we had no choice to do that. And, we need to build up recruitment, but we're hiring. We have advertised that we're hiring, and they look at it. But from a financial standpoint, when we look at that with the current situation, it's 6 of one, half a dozen of the other. So we don't think, the line items may switch, but the bottom line of what we're paying for labor won't.
The cost isn't the big deal. If you look at the research has documented occupational health disparities, including higher rates of work-related injuries among temporary workers compared to workers in standard employment arrangements. And we're talking about hospitals now, healthcare. And also, a contract employee knows that they're going to be here for just a short period of time. So if they see something that's going on that, should be reported, they're not going to report it. They're going to collect their pay and they're going to go on.
We haven't found that to
We
be
get
true.
better care.
We haven't found that to be true.
Please
what?
let me finish.
Oh, sure.
Okay? Mm-hmm. Okay. It's right here. A long study. I'm not, you may think that you have got some insight into this, but it's just not true. Now, if there's a problem with keeping full-time employees, then that's the employer's problem. That starts at the top.
Have you found, Cynthia and Jody,
Starts at the top.
that we've had...
Harry, let's stay on point, on focus. This is about a financial overview. And we're not going to
I thought we
address
were
a
gonna have a
national
workshop.
survey that has
I thought we were going to
hospitals.
have a workshop.
We are.
Well, it's more than just finances.
Have you found that there's
Person that
been,
asked about finances, it's not here.
connecting to the,
We're here
to the
to ask other
report
questions.
about injuries, have you noticed over the last 12 months that there's been more injuries reported from your contract people than you have your full-time people or your PRNs who are local? Is it different in injuries regardless of department?
We're injury-free for all staff.
Oh, that's great to hear. Okay. It could be that study came out of larger hospitals, Harry, and not small hospitals.
Well, I think the bottom line, as far as the plans and direction of this hospital, the preference is for local employees.
Mm-hmm.
But you can't pluck them out of the air.
They've left.
And
They've left.
there's a crowd that left.
Please.
There's a crowd that didn't report problems, and they're not here right now. So the fact of the matter is that statistics are good for large numbers, but in a small environment, you can't predict. They don't predict in a given situation what's going to happen. But we prefer local employees. We're searching for local employees.
I'm all for it. The city
And
wants
our employees at the
our
present time
citizens to
are not coming up with a lot of, they're not coming to complain. Maybe we've, with our, maybe
You
we've
have
frightened them,
not
I doubt it.
heard the
Now, Mr.
complaints.
Meyer, please, wait a minute.
You've
Go
not
ahead.
heard the complaints? We've had council
Davis.
meetings with lines of people complaining.
We've had people who formerly had problems. We don't have current. I've had sat in here
I know.
while those people have come in.
They're not
and talked
employed
about
anymore.
something that
All
happened
right,
3
we're
years
getting
ago.
off track here.
We're talking about what's going on right now. Our attention is focused on it because we don't want a repeat of that.
Okay, what's the turnover right now?
You've been supplied that, just sent the new one. It's 2 in the last 6 months?
2 were fired recently, this last week.
Not fired here.
Let go, laid off, right? 2 people been laid off this last week?
Actually, they were contract employees, Harry, and contract employees are for a year, correct? And then they have to wait out, because we have had contract employees that want to work for us, and we've hired them, but there's a waiting period of, what, 3 months? Or 6 months? What is it, 3 months?
Depends on the contract.
Another problem with contract employees, it's they have to be trained when they get here. Because, of course, it's a different facility, and that takes someone else's, has to leave their job and train that contract employee, and they can't go back and do their job alone. There's lots of
I don't-
reasons.
That's not an
why-
accurate representation
That
of
is
how our
totally
emergency room
Wait,
operates.
Mr. Holyfield, you had a question?
I have a budget question. I'm not a finance person. I dealt with budgets all my life, my professional life. But as Sandy said in the workshop, hospital budgets are different. So I'm even more lost when it comes to looking at these numbers and stuff. But I do ask people questions. And I did have a person, because I do want you all to see us kind of the front line of the community, because we are elected by the people to represent them on a lot of different issues, and this is one issue. So I did have one person ask me to ask this budget question. Why is it that there is a loss of $602,000, right? But the balance sheet is down $1.9 million. Does that make sense?
It's easy. We've explained part of the 602 several times, and that's the detail here that we had the equipment, which was an unanticipated hit of a lot of money. We had the backlog of Cerner. We withheld payment from Cerner for several months because we weren't getting the kind of service that we needed and the help with it. They have since corrected that. So we wrote a $560,000 check that hit our bank balance, obviously, but what Cynthia did is she retroactively and proactively expensed that out. So while it hit our bank balance, it didn't hit 1 month in advance. The cost that we have, you saw the inflation figure, you saw the supply figure. We have invested in the hospital with several pieces of equipment, new heart monitors that were woefully out of date, crash carts, procedure carts.
Right.
Those investments into the hospital we felt were extremely necessary. They do not make up the 100% of the 602, but they make up darn near 80% or 98% of it. The biggest and unanticipated was the technology and the equipment, but we had no choice, and we're still working on that. But our technology was terrible and was subject to several breaches. So
if you add all this up, it comes to 1.3.
I'm sorry.
If you add all this up, it comes to 1.9 actually with the 602,000 included.
Probably, I don't have that in front of me, but
I don't have it.
I mean, yeah, I mean, are we at a deficit? Yes. Will we wind up this year with a deficit? If you listen to our workshop on the budget, because we're going to have those periodically, we don't know, but we're probably going to plan for a deficit. This is a very strange environment.
Right.
There are tons of changes. We could get hit at any time. Cynthia's looking at a bunch of code changes that could get really kind of scary with it. So we don't know. But yeah, anticipated deficit, we are. But we know that what we're investing in the hospital for the long term and the short term is important, it's necessary, and it is for the future of the vision that we have for it. Sorry.
No, I was going to elaborate on that. I mean, yes, we current to date do have a loss. I will not, I mean, that's what it speaks. I mean, we did have a decrease in revenue, billable revenue services. I mean, that is anticipated. That is anticipated every January, February, and March. Unfortunately, we did have our decrease was greater than we anticipated. Our month of May, we hit and exceeded actually historical numbers for that. We billed out almost $800,000 in billable revenue. That does not count into our CMS Medicare payment, which would put us at over $1 million of revenue for the month of May, which exceeds where we have been as an REH.
Yeah. I'm sorry, I've got to interrupt here.
No, let me finish, please. So within that, that is just one aspect of it. I mean, our monthly billable revenue has increased and will continue to increase. I do foresee that. On the other end of that is, I mean, healthcare finance is a beast in itself. There's many reasons. It's a specialty within people to get certifications and degrees in that. We have worked with Forvis. We do our cost report. That is with CMS and Medicaid. They kind of look at all of our expenditures across all the buckets, all of our payer sources, kind of take in our patient mix, and we do a yearly cost report. That is an actual requirement for CMS, Medicare, and Medicaid. And then within that, typically, we do get additional reimbursements at the end of the year based off of our profit or loss, based off of our expenses and our patient mix and payer mix and things within that. So I can say within our 24 win, I think we were looking at about a $300,000 payment reimbursement from Medicare on that. So I don't think our Medicaid win is there. But I mean, there's many facets of working within the healthcare finance that you can't just look at this month and fixate on a number, because you have to look at the whole picture and kind of take in leading. We know when we file a cost report next year, by next May, we will have a reimbursement on some of this. So there's kind of, it's an ever moving kind of.
I realize there's a lot of factors to this.
Yeah.
And one more question before I give up the podium here. Someone asked me to ask about the $3 million COVID money. Are we secure that that's going to be reported correctly and that we won't have to pay that back or anything?
We just answered that question. I think you got a copy of that. 3.66 million is what we had. It was under the Alliance management. And we could not get from Alliance all of the receipts. So Forvis recommended that we carry that as a liability, which we agreed with and is carried. We've discussed that several times, and so we're carrying
that was before, even with me. And on that note, Sandy, it was because that money was received during that COVID pandemic and during the transition of the hospital commission taking back over. And then there wasn't a financial person on site at the hospital to ensure the accurate documentation, tracking, trending of all the expenses, all the receipts, all the paper trail essentially was there to validate the money. So then when I did do the audit with Forvis, we absolutely said we agree with that finding. We do want to just allocate it as a liability out there just for the ever so coming if it was to come back. It's not that, we did have expenses, we did have some information, but we couldn't 100% nail down to the number of what they had. So
you know how much money we're going to have to pay back?
We didn't, we just kind of that was the amount of what that grant was. So we just recorded the whole thing as a liability. We do have some files. We were able to, again, to find some stuff, but that was preceding my times and preceding even with somebody there. So, we took the higher number. We just chose to go at the safer route of within recording that liability so that there was never a question if they did. So
that's a loss to the hospital then, ultimately?
It's just a liability. It was a grant money, so it wouldn't be a loss. Because it was grant money for the hospital during the COVID pandemic. So
we just basically didn't get the money?
Correct.
Okay. Thank you.
I just want to keep things honest. One of those people that was let go last week was a full-time employee. They weren't contract, okay? Don't say they're all contract. There was a full-time employee.
We had, there was a full-time employee who's, am I allowed to, if I don't mention names, am I allowed to talk about departments or that?
They were laid off.
That way, there was a change in, a department was no longer needed a full-time employee, a full FTE. That particular person was offered another position within
Someone
the
else's
facility.
job, yeah.
Excuse me, was offered a position, a full-time position within the facility, so it would be a full-time, no loss of hours. And my understanding, if it's the same person, I've only know of one person who had it, there was a department that had an FTE reduction, that this person chose to not stay within the facility and seek employment elsewhere. And that's all I'm trying to say to that.
What I'm trying to say is, let's keep it honest.
We are.
That was a full-time employee. That wasn't a contract person. That's all.
All right,
That's
very
all.
good.
Just as a historic perspective, the Arkansas Business Journal did a review of REHs converting last October. That was a good article, and it pulled each of the hospitals' history financially, and it's interesting, from 2018 to 2023, Eureka Springs Hospital has lost anywhere from $1.6 to $3.3 million. And that's something that the commission looked at that went into the decision to relieve Alliance of the duties, take it over. And we've shared with you before the history of where we were in a deficit, that chart that I handed out at one of the council meetings, that the commission and the staff dug us out of a hole and got us into positive thing. I also want to make a remark in that last October and November, I think, there were 2 months last year that we actually flipped into the black, which was great. So we know that it's possible that we can operate in the black. When we put our budget together, we had obviously not a lot of information as far as REH. We had no information as far as what we were going to go through with the surveys. We budgeted for a break even because, again, there are so many unpredictable things, we didn't have a choice. We don't think that we're going to hit the 14 million that we projected, but we should know within the next 2 months what we will hit. But it's not going to be half of that. It's going to be closer to the 14, I think, with that. We obviously need to build outpatient services. We need to do a lot of things. Our plans are, we've gone through, we've got our REH consultant has given a plan that identified some revenue options and services to go into that basically the staff had already identified and made recommendations, so we're actively going to pursue those. Maternal care, mental behavior, those things keep coming up. We're hoping to work with UAMS with that. We're looking at if we can afford it. We're looking at our own transport van that also might be a mobile clinic to be able to go where patients are, because transportation, particularly in our area that has older patients, transportation is an issue. It's clearly an issue when it comes to the winter months in Carroll County. Our service area seems to be growing a little bit more because of other lack of services. So we're planning those things in advance, but we've got a combination of having to maintain and control and reduce expenses while we increase revenue. That's typical. That's what you do. Looking at telehealth, looking at other ways to save money, consolidation. Becker's Health just put out a report of what the future workforce is going to look like, and it's going to be fewer doing more. Cross-training, which is one thing that we've already started, the staff's already started cross-training within the hospital, which makes all the sense in the world. So will there be, Harry, a reduction in staff? I can't answer that. There might be. The services won't change. The quality of care won't change. In fact, I think it's increased dramatically.
Well,
that's our main focus. That is
question about the training. Will the hospital pay for training?
We do. Depends on the training, right?
We have training available through Health EDU, where the nurses or any clinical staff can earn CEUs. We cover that. And we send our nurses to trauma and TNCC. We cover that cost. So yes, sir, we do.
In certifications, like Terry was,
That are required.
is it boiler certified? That sounds
Correct.
weird. I'm certified in boiler.
Well, Sandy, circling back to what Bo might be able to help us with, I've been thinking about our clinic and our telehealth, and I'm wondering if we can get from him, as we continue our discussions with him, if we could get some info on any of the other small hospitals that also have a clinic, to see what they're doing, and then also these small hospitals that may have already implemented the telehealth. I mean, we know that behavioral health needs are just off the chart, and not that our county is any better or worse than any other county in the area, but we certainly need it. So maybe, I hope that maybe Bo has some figures and some ideas on
UAMS might too.
yeah, that'll be good.
Yeah.
Because we certainly have the space for mental health, telehealth, and not to talk about any particular.
I thought Dr. House had several suggestions.
Not talking about any particular folks who might have utilized our clinic in the past, to see how those relationships are or were, but what different dermatology or just different urology specialties could come in and utilize that clinic space for
Well, and I
revenue.
think since the topic is financial too, I think, doing a cost benefit analysis is going to be kind of critical with that.
Okay.
Kate, sorry. I was going to say, to kind of, on what you were saying there, we do work closely with a lot of the other REHs to kind of bounce ideas, kind of work together collaboratively as we move through this. I mean, we have and continue to, so we can kind of discuss some of this even with the other REHs that have made these changes, and kind of seeing what service lines, what they've done, or how they've kind of helped improve the other outpatient services too. They're really good to kind of collaborate and work with us too, so we can do that too. So.
Yeah.
I know that y'all have lots to discuss in the commission, but we're kind of here to interact with you. We want to ask questions. And so, you have suggestions for the rest of the hospital bunch. That's cool.
Our whole intention is, of course, is to look at new services to help that budget.
I want to ask questions.
I thought we were here to talk about the money and the budget.
I thought we were here to discuss the hospital.
It's a budget issue.
A budget issue.
We're talking about finances.
So how long have you been off of Divert?
Yes.
Huh?
We are officially off of
When? What date?
Monday at 2 o'clock.
Monday, 2 o'clock?
Monday morning.
How long were you on Divert before that?
We just sent you that information, Harry.
You sent me that information.
Yes.
It was November, wasn't it, of last year?
No.
Been on Divert since last year at November.
No.
Except for 3 days during February, right?
The point is, we're off Divert. We know we were on Divert.
I'm telling you, this is just snow job again. I want to know why. Why we're off Divert in February and something happened.
Mr. Meyer, what's your point?
People ready to be trained. The hospital would have had an operating blood bank and everything because it was operating in February.
Mr. Meyer, what's your point here?
My point here is competency.
Are you saying that we don't have competent help?
We don't have a competent leadership at the hospital.
I'm talking about, we have competent doctors.
We do not have competent leadership. We do not have a competent administration.
Yes, we do, Mr. Meyer. Yes, we certainly do.
There's a point.
But the evidence proves otherwise.
Mr. Meyer, wait a minute. We're going to have to agree to disagree on this. Now, if you want to be on the hospital commission, you're more than welcome to resign from council. And I'll be glad to
Mr. Mayor,
on
our last meeting, you lied to me.
I think we are close to concluding this workshop.
You lied to me.
We can discuss that later. Now, we're talking about financing right here.
Well,
Now,
you
we're not
gotta have a
talking about
hospital when you
competence
want
of the
finance.
hospital.
Okay?
Now, you're talking about past issues, we're talking about present. I'd like to see some solutions. I don't want to, we know what the problems have been. Let's see what the,
There are still problems to solve.
and I think the commission is working on those right now. I don't think the council is helping in this respect.
I have no confidence in the hospital.
Have you gone to the hospital? Have you gone up there and visited the facility? Have you looked at it? Have you gone to the
I've been
facility and
in
looked
that
at?
facility.
In the last 6 months.
No.
Okay.
But that's not the point. The point is, in the last 6 months, you haven't had a lab.
Does any,
In the last 6 months. And you have to have a lab for a hospital.
We understand. We have a lab. We're off divert. We're going forward.
For a little while.
Going forward.
Let's hope so.
Thank you for your hopes.
All right. Do we have any other questions? Do you have any other final comments?
None.
All right. If there's nothing else.
This is going to be fact-finding. It's a snow job.
All right. We'll go ahead and adjourn this meeting. I thank y'all for being here
Thank
very
you.
much.
thank you very much. Thanks
Thanks,
for your
guys.
patience.
Great questions, Councilman. Appreciate it.
Anybody want a copy of the